I'm Dr. Constantinides, and today we're going to be talking about rhinoplasty. Our talk is going to last about 30 minutes, maybe a little bit less than that, and there'll be time at the end of the talk for everyone to ask questions. So here with me is my cosmetic consultant, Devin. I don't know if that's your title, Devin, or not.
Perfect.
And Devin is going to be your go-to person if you decide that any of this sounds interesting and you'd like to take the next steps with us. But most importantly, for now, Devin is the go-to person for fielding questions. So in the webinar uh, sort of bottom bar or top bar, or however you're looking at it, there's a Q&A box that you can click and type whatever questions you might have. And after we're all done here, we'll start to answer some of those questions. So without further ado, let's start talking about rhinoplasty. So rhinoplasty is basically has to do with nose, right? So doctor, can you help me look better? Doctor, can you help me breathe better too? And those are the really two important questions that we're going to try to dive into in a lot of detail in the next 25, 30 minutes. I'm Manas Constantinides. I'm a double board certified facial plastic surgeon that works here at Westlake Dermatology in Lamar Central, which is 38th and Lamar. And Devin is also our consultant that sees patients here as well as other locations. And there at the bottom at Dr. Constantinides is my Instagram. And so please check that out if you'd like to see more examples of the kind of work that we can offer for you. We'll talk about what double board certified means in just a minute. So what do I know? I mean, here I am. It's a long Greek name sitting here in Austin. What do I really know about rhinoplasty? Well, I've listed here kind of a brief sort of summary of my resume, where I went to school, where I practiced. I'm really most proud of the 1994 to 2015, those 20 years. I was director of facial plastic surgery in the Department of Otolaryngology. That's the ENT department at NYU in New York. And I also ran a private practice there. And basically, the scope of my teaching and research and surgery while in New York was mostly rhinoplasty and revision rhinoplasty. I do more than that cosmetically now here in Austin, but there I was really pretty well known within both New York and throughout the US as well as throughout the world, frankly, as a rhinoplasty expert. I've done probably over 5,000 rhinoplasties at this point in my career, and still really love the surgery. It's my favorite of my top two surgeries. Rhinoplasty is my favorite. I'm double board certified in facial plastic surgery and in otolaryngology, and I think that becomes important. We'll talk about why in a little bit, and really proud of the accomplishments I've done academically. I have 35 peer-reviewed publications, 21 of which are in rhinoplasty. I've edited 2 books in rhinoplasty. I have 21 book chapters in various books on plastic surgery, with 15 of those book chapters in rhinoplasty. In fact, I have 3 book chapters in this book that just came out called Rhinoplasty Cases, and I'm really proud of my ongoing contributions for the literature and for teaching in rhinoplasty. So let's talk about what rhinoplasty is. So there are 2 types of rhinoplasty: functional rhinoplasty and cosmetic rhinoplasty. Looking at these 2 patients, can you tell the difference? Which one's functional, which one's cosmetic, if it wasn't labeled? Probably not, because in both cases we have crooked noses and noses that could look a little bit better. And the only difference is that under functional rhinoplasty, this patient can't breathe through this nose, And under cosmetic rhinoplasty, this patient has no problems breathing. So, but the surgery is important that we do it in a similar way. And we'll talk about that in a few minutes. So, so what does rhinoplasty do? Really, it should change the nose so that the nose no longer draws attention to it. You should keep looking like yourself. It should look like the nose you should have been born with but weren't. And most people should not be able to tell the difference between how you looked before and how you look now if they haven't seen you all bruised up. So, and because no one's looking at it before and after, you should just look like a better version of yourself. With functional rhinoplasty, we also want to improve breathing. But even with cosmetic rhinoplasty, one of the main complications of rhinoplasty is new nasal obstruction. We definitely want to protect breathing if you don't have breathing problems with this surgery. So after her functional rhinoplasty, she breathes better, but boy, doesn't she look better. And the things that we like to see with noses are a shape that's not crooked, that's more midline. I think we've achieved that for her. We like to see these straighter lines from top to bottom. So on the before view, she's got crooked lines, of course, because she's crooked, but also they're not even. They're uneven, and they end in a wide tip. And here we have straighter lines from top to bottom, more even, that end in a narrower tip. And so aesthetically, what that does is enhance the eyes. It makes you look better, not different really, but better. Profile, here we have a result that's a shorter, more elegant profile, and one that fits her face better. This is really important to notice that this looks a little scoopy, right? So you might say, well, that's a little done looking for me. I don't like that. But the point is, rhinoplasty should be different for everyone, or can be different for everyone. And if you look at before and afters of mine on Instagram or my website, you'll see that everyone's nose, there's no Dr. C nose. Everyone looks different because the goal for each patient is to try to make them look like they want to look. So a shorter, more elegant profile. And of course, this is where we really want to see improvement is in the smile. Before surgery, the nose overwhelms her smile, takes attention away from her eyes and away from her smile. And here, after surgery, her eyes are brighter and her smile is unmasked. Now, what's really kind of cool in many patients that I see after surgery that come in for their pictures at 3 months, and these are 3-month follow-up pictures. At 3 months, what's cool is that they all often will come in made up. And it's not because we ask them to do that, it's just because they just feel so much better about themselves, I think. Anyway, this patient, super happy. This is the same patient and her quality of life surveys before surgery. So we ask patients to fill out these 2 surveys, quality of life surveys before surgery. So, and this one on the left is called the nose scale. And the nose scale is basically a nasal obstruction symptom scale. And if we add up these numbers and they're 10 or greater, then this is a significant quality of life problem for the patient. With surgery, with successful surgery, we can expect a 2-point improvement in this quality of life, in all these points. So the 4s don't go to 0, but they go from severe to moderate problems, and the fairly bad problems should get back to a very mild problem. These are significant improvements in quality of life for patients with obstruction problems to start with, but it also allows us to sort of counsel the patient as to what kind of improvement they can expect. And if these are realistic sort of discussions that we have to make sure that everyone's on the same page as to expectations with outcomes, both functionally but also aesthetically. Here on the right, we have a combined quality of life survey called the Schnoz survey, which the top questions are similar to the nose scale, where we're asking about function. There's a psychologic sort of mood question in there, and then the rest is on shape. And so we see in this patient that we just saw her results, she had significant issues with both breathing, but also the shape of her nose and how it affects her day-to-day existence. So those are all really important things to talk about. Again, with successful surgery, we can see a 2 to 3 point move on these scales. And again, it gives an idea to patients as to what they can expect. So every patient that has surgery, I fill out this diagram as to what I did with surgery. And these diagrams I go over with patients after the surgery, because I think it's really helpful for patients to know and to understand what's happened for them. And so here, if we start here, we see at the top here that this was a joint case with Dr. Akal. Dr. Akal is a sinus surgeon here in town, and this patient also needed sinus surgery because she had chronic sinus problems. So we joined forces. He came in and did the sinus part of the procedure first, and then I finished with the septorhinoplasty. With the septoplasty, this is a side view of the septum. The top of the septum is the top of the nose here. The bottom of the septum is the bottom part of the nose. And we can see in her case, the bottom of the septum is not supporting the tip. The tip is drooping down, needs better support. Well, her septum was massively deviated. She had a large spur on the left side, and her septum was deviating to the right, more to the front. So we removed cartilage to repurpose and use to build strength and support in her nose after surgery. This is key to successful rhinoplasty. There are many surgeons that aren't comfortable taking cartilage out of the nose, and many rhinoplasties are done where there is no cartilage added to the nose. All this does is make the result less secure for the long term. Adding structural support is a really important part of septorhinoplasty, and it should be done, in my opinion, for every rhinoplasty that's done. So I don't do a rhinoplasty without doing a septoplasty, without taking cartilage and help stabilize the nose, even in just pure cosmetic patients, because without that, we aren't guaranteed that the results are long-lasting. And in cosmetic patients where no one has trouble breathing, we don't know that the airway will still stay open if we don't support it further. So septorhinoplasty, cartilage is removed, a big spur on her case is removed from her left side here, and what was left was still a crooked front part to the septum. So I divided the septum, overlapped it, and re-sewed it together like I show here to create a straight line septum here. However, doing that caused a depression of the top of her nose. So when I went to take down the height of the bridge of the nose to give her a prettier profile, yes, we took down bone, but didn't take down any cartilage because the cartilage position had already fallen to the right place. We strengthened that position with this cartilage graft underneath the sidewall. It's called a spreader graft. And then we helped stabilize the tip at the bottom with this graft to help stabilize and support the tip. And also I use grafts along the side of the nostrils, rim grafts, to prevent pulling up of the nostril and to create a nice transition between nostril and tip. So because of all the structural support we added, she now has a stable result that will last forever. Nostril shape is improved, position of the tip is better, and everything is nice and stable. So let's talk about that cosmetic patient we saw before. And this is an opportunity to talk about photo imaging. I really don't think that rhinoplasty should be done without photo imaging. Photo imaging is an opportunity for the patient to express what they want to see as an outcome, and it's an opportunity for the surgeon to be able to talk about what limitations the surgery might have for them. So this is a right profile of this patient before surgery. Here is her imaging that we decided. She wanted a natural look. without an overly done look. And then her actual 3-month outcome is very close in terms of rotation and position of the tip to the imaging. She has a little puffiness still at the tip at 3 months, but otherwise pretty good. We image always in 3 views. So this is an oblique imaging before, what she decided she wanted after the surgery, during the surgery, and then after the surgery at 3 months. You can see this result is a little different than the imaged result, right? Imaging is about 90% accurate, but this in rhinoplasty, with an experienced surgeon, the surgeon listens to the nose, and the nose will kind of tell me where it needs to be stable over time. And in her case, her tip wanted to be a little bit less projected than that, wanted to be a little bit further down. So adjusted the bridge and tip to sort of fit one another, and this looks very natural for her, and I think a better proportion for her overall facial size and shape than the imaging. So at the end of the day, it's really, and she's super happy with this result. Otherwise, we wouldn't be showing her. So super happy with the outcome, listening to the nose, stabilizing it where it needs to be, so there is long-term improvement. Straighter here, straighter lines from top to bottom with the imaging, and boy, with surgery at 3 months, really very pretty lines from top to bottom, ending in a really pretty tip. And look at how her eyes just open up, and she looks so much better after surgery than she does pre-op. But notice that change also is seen with imaging, that we see her eyes open up, and her outcome with the rhinoplasty should make her look better, not just make the nose look better. Here's a case example, another case example of surgery. This is these are before pictures of this patient with her smile. She thought her nose was long and overwhelmed her smile a little bit. It was a little bit crooked. Oblique views. There's always a better and a worse side. If you look at your own sort of pictures, you'll know that you have a better and a worse side probably. And it usually has to do with asymmetries due to deviations. So in her case, this side of her nose is going away from the camera. The height of the bridge, the bump is a little higher. Here it's coming towards the camera. It looks a little straighter. Both look a little long. Maybe this looks a little longer than that. And the projection looks different because the nose is tilting left, so this looks more projected. Here it's coming towards the camera, so the tip is less projected. After surgery, profiles pretty similar, but those asymmetries due to that deviation are still there. So we like to do on-table videos these days. So here is her on-table before surgery.
Hey guys, up to rhinoplasty today. Bump improved, nasal length shortened, tip definition improved, rotation improved. She should just love it.
So those are my, goals for her. Not that they already happened. So this is before surgery. And here's her before and on table after surgery, where we created a nicer profile. It's immediately after surgery. We like to take these pictures so we can show these to the patient the next day so they won't worry with a cast on for a week what they're going to look like. And then alar-based reductions to narrow the nostrils overall. And here's her on table after.
All right, here we are at the end of the surgery. Really nice shortening, natural appearance, alar-based reductions, make the nose and tip look much narrower, but balanced with her face.
So this is my favorite part of all my patients' journeys, their kind of first look. This is gonna sound it's gonna sound fake to y'all. I thought when I listened to it, gee, that sounds like I coached my patient. I didn't coach her at all. This is her first impression after her cast came off a week later.
Oh, I'm scared. Whoa. Oh my God, it looks so good from the sides. That's crazy. Wow.
You look amazing.
That's crazy. Thank you.
You're welcome.
I love it. That's crazy. Oh my God. I have a new nose.
Just my absolutely favorite time. Uh, just joy, right? Joy for the patient, joy for the surgeon. All right, so let's talk about how to find your surgeon. So obviously, everyone who hopefully is on this call has been and seen some before and afters. Look at before and afters online from websites and Instagram. Keep in mind that I guess TikTok too, although I'm not on TikTok, so I didn't list it here. Keep in mind that surgeons only post their best results. This is just the nature of the beast. Surgeons, if you looked at a sequence of outcomes, you'd see good outcomes, you'd see some outcomes you wouldn't be really, thrilled about. And the more experienced the surgeon, the fewer outcomes there are that the surgeon is not thrilled about. In my cases, um, at this point, I really kind of know what's going to happen with noses afterwards, and they're stable and they don't change much over time. So I'm confident about my outcomes with my patients, which I think patients appreciate. Um, you want to search for a surgeon that specializes in septorhinoplasty, not just rhinoplasty. We talked about this before. Septoplasty is an important part of rhinoplasty. Cartilage from the septum must be used to stabilize the nose for good long-term results. You absolutely need someone who is skilled in being able to take cartilage from the septum and straighten it if needed. I think that surgeons should be board certified for at least 10 years by either the American Board of Facial Plastic and Reconstructive Surgery or the American Board of Plastic Surgery. There's a third board, the American Board of Otolaryngology, head and neck surgery. I am board certified in both that one and the Facial Plastic Surgery Board. And surgeons who are board certified by the American Board of Otolaryngology are competent nasal surgeons. They've been trained to do a septoplasty and know about rhinoplasty. But without 10 years of experience, and in my opinion, without further board certification, they're just not going to be the best of the best. So, and why 10 years? It really does take 10 years for a surgeon to understand how to get good long-term results. They say it takes 10,000 hours to become competent in something. I think the 10-year period is an important one to keep in mind when you're looking for your surgeon. Now, I was in practice for 20 years in New York, and the first 10 years in my practice, I think I was getting pretty good results, but it really wasn't until after that 10-year mark that I could get results that were reliable and long-lasting, and that I could predict the outcome pretty reliably. Meet your surgeon in person. This is really an important thing. I think you need to be sure your surgeon will help you through the long healing process that rhinoplasty involves and support you through any challenges in healing. The two of you really need to be a good match for one another. And if you're not a good match, move on. If you don't get the sense that your surgeon is going to pay attention to you and support you, then find someone else. Do photo imaging. We've already beaten this to death, I think, but I really think it's an important part of knowing that you're on the same page with your surgeon aesthetically, and that your surgeon can point out what he thinks would give you the best outcomes, and you can chime in as to what you'd like to see. Obviously, communication is vital to any good relationship, and this is an important relationship you're building with your surgeon. All right, some other sort of more routine questions. How long does rhinoplasty take? Well, it takes about 3 hours in my hands. What kind of anesthesia do you use? We use general anesthesia. That means you're asleep with a breathing tube that helps you breathe. You won't have any memory of anything unpleasant during the surgery. The breathing tube is an important thing to protect your airway so that little amounts of blood that might get back there aren't aspirated, or you don't breathe them into your lungs that could then cause pneumonia, which would be a real problem. Well, I'm scared I'll feel pain. Really, pain is not a big part of the recovery with rhinoplasty. We give celecoxib, which is Celebrex. It's a non-steroidal like ibuprofen that doesn't cause bleeding, and it's not a narcotic. So you take that around the clock. You take Tylenol, you use lots of ice, and many patients don't need a narcotic. The ones that do need a narcotic need it for about 48 hours. That's when sort of pain and swelling peak. And after that, hardly anyone needs a narcotic at all. So we prescribe a narcotic to everyone if they need it, but most patients don't need it. The worst part of the recovery is complete nasal obstruction for the first few days. It's really about 4 days before you start to get a little airflow through the nose after surgery, and that's just all from swelling. At a week, you're getting some airflow, but it takes usually a month to feel like airflow is better than it was. We don't use packing in the nose. Some surgeons still do. We don't use any funny long, tubes or stents that can cause pain coming out. I think, I try to do the things that I think I would want to have done to myself after surgery, and have learned how to avoid many of the things that some surgeons are doing that just aren't necessary. How can you heal faster? We'll give you a lot of information at your pre-op visit 3 weeks before your surgery on how to heal faster, dietary recommendations, what products you can use, and we'll talk about lymphatic massage post-op. And how long do the results last? Well, they do last a lifetime. The nose will age over time, but will age less, will change less than it would have without surgery. So recovery timetable, day 1, we see you in the office to make sure you're healing up okay, but most importantly, to show you how to take care of your nose and review all your instructions the first week. And that's when I'll show you those before and after pictures that we've taken. On day 7, the cast and stitches are out, any intranasal splints are removed. I'll go over that drawing that I showed you about what I've done. We'll show you pictures of the inside of your nose if this was a functional surgery done for breathing improvements. And I'll review taping if needed. Taping is not needed in everyone. Taping is only needed, and by taping I mean taping the nose after surgery at nighttime only to help to reduce swelling faster. Most patients who are thin-skinned or medium-skinned don't need taping. Some medium and many thick-skinned patients do. It'll help you heal better faster, but if you tape for no reason, it's really not helping at all. So we'll go over that. I'll show you how to do it for you. And then most patients return to school or work, still a little bruised, but not bad. By the second week after surgery, bruising is gone. You can get more active. By a month, your smile is back. Initially, the smile is real stiff. You're not seeing as much tooth. By a month, that's all softened, so your tooth show is normal. Full aerobic activity, submerging in a pool is okay. And if you've been doing taping and it's not doing enough, then we'll talk about maybe doing some steroid injections to help bring down swelling even faster. At 2 months, it's okay to submerge in a lake. By 3 months, you're 90% healed. The tip is still stiff and numb, but the position of the tip is pretty much where it's going to be. There might still be a little puffiness, as we saw in that 3 months after for that one patient, but pretty much the shape is going to be what it is. And then at a year, we say you're fully healed, although we know that the skin can thin over time even longer than a year after rhinoplasty, but we talk about a year as fully healed because that's, if there's anything that's a problem, if there's some nostril asymmetry or something that's not quite right with breathing, we can go in and do a touch-up procedure. There's a 3% risk of needing that in my practice. I personally see you at every visit. I don't leave my nurses to take care of you. I think it's really important in rhinoplasty to make sure that the surgeon follows you carefully so that we can pick up on any issues and address any questions you have. So this is where Devin comes in. She'll contact you by email. Is that right, Devin? You'll contact everyone by email? Yes, Devin's nodding yes. Contact everyone by email. And you can schedule a complimentary consult with Devin if you want to do that. You can do that by scheduling online or by emailing her. Her email is devinw@westlakedermatology.com. You may also schedule a paid consultation with me if you'd like. If this is a breathing problem, in addition, we can bill it to your insurance. You can call the office directly to do that, or you can visit our website at westlakedermatology.com /book online to book a consultation with me. And then here's our 10% off offer. If you're interested in getting 10% off, you'll get a quote from Devin that includes the 10% off. If you'd like to take advantage of that, you must book your surgery. You must be on my schedule within 30 days. That doesn't mean the surgery has to be done within 30 days, but you have to actually schedule your surgery within 30 days to get the 10% off. And Devin can help expedite that. We obviously look forward to seeing you in person. So thank you very much for all that. This is I never hadn't visited the Houston Rodeo until this year. This is me and my wife at the Houston Rodeo this year. Wow, we had just such an amazing time. The rodeo was even better than the musical guests that we went to see. Better than Old Dominion, in my opinion. Anyway, had a wonderful time. Look forward to taking care of everyone. Devin, do we have any questions?
I did have a couple come through. Would you like me to go ahead and start reading them?
Yeah, would you mind?
All right. So first one is, does the nose keep growing as we get older?
So, thank you for the question. I think we talked about that a little bit. So the nose doesn't grow. What can happen to the nose over time is that the ligaments that hold the cartilages together can weaken, just like everything else weakens as we get older, and you can get a lengthening of the nose. You can get a separation of the cartilages. The tip cartilages themselves can become more rounded or more asymmetric. So it kind of looks like everything's growing. It's not growing. With rhinoplasty, the nose should be stabilized, so those changes are less. You'll still have some of them, but they'll be less than they would have been.
Perfect. Next question is, if you don't have enough cartilage, do you use cadaver cartilage?
Yeah, okay, great question. So, so the answer is it depends on what I'm trying to deal with. So if we don't have enough cartilage, that usually means that the patient has had previous rhinoplasty or previous septoplasty. I have not, maybe once I've had to use cartilage from somewhere else in a patient who has not had previous septoplasty because there's just too much weakness in the nose to overcome with the limited amount of septal cartilage that's available. So my first choice for cartilage is usually the ear, not cadaver. Ear cartilage is your own stuff. We know it'll last forever if we put it in the nose, and it's great for adding support in certain areas. It's not great for adding major support though. So if we need major support, then and I'll predict that with you at your consultation, then my second best choice is actually using your own rib. We much prefer rib over cadaver cartilage. Studies are a little bit mixed as to the efficacy of cadaver, if it's as good as your own rib or not. I prefer your own stuff if we can use it, so we use your own rib. The problem with your own rib is that it calcifies as you get older. So over the age of 50, then I've learned that the rib usually is calcified, very hard to use, and so I typically at that point, if ear is not enough, we'll turn to cadaver cartilage. So that's a long way of saying, yes, I use cadaver cartilage, but really only as a last resort if other things aren't available or aren't going to work as well.
Perfect. Any issues or difficulties treating a bulbous tip?
Yeah, I mean, the issues we worry about bulbous tip. So a bulbous tip comes in two flavors. It's a tip that is bulbous because the cartilages are sort of broad and wide, and there's a tip where the cartilages are broad and wide, but also the skin is thick. So with the cartilage issue, there is absolutely no issue reshaping those cartilages so that they are narrower. But then if your skin is too thick, then the skin won't drape over that new narrow framework I've built, and that interferes with how much narrowing we can get. So, I go through that with my patients during their photo imaging. Because with photo imaging, I can show you what I would predict as the outcome for you, depending on skin thickness primarily. But a bulbous wide cartilages with thin skin, no problem getting a really nice outcome.
Perfect. Is it more difficult to perform a rhinoplasty on a patient who's previously had a liquid rhinoplasty?
Great question. Wow, great questions today. So liquid rhinoplasty means filler has been put into the nose. I do liquid rhinoplasty. And I've done liquid rhinoplasty in someone who I know I'm doing a rhinoplasty on, but that she has to look good for a wedding or something. And so we can plan to dissolve the filler, which has to be done if you've had a liquid rhinoplasty, before surgery. And that's usually just fine. Now, liquid rhinoplasty depends on what the liquid is, depending on what the filler is that was used. If it was a hyaluronic acid filler, I, for example, for liquid rhinoplasty, use Voluma because it's structurally the best filler for the nose, I think, and doesn't flow, doesn't move. So if it's Voluma, we can dissolve it. Voluma is hard to dissolve. It takes a lot of stuff to dissolve it, but it can be dissolved, which is fine. There are some fillers that aren't hyaluronic acid fillers. They're either permanent fillers or fillers made with other particles. And those fillers, if cannot be dissolved, that's actually a real problem. And those patients may or may not be able to have a rhinoplasty. Sometimes we can go in with surgery and remove those particles, but very often there's scarring and the results tend to not be not as good. Hopefully so the short answer, liquid rhinoplasty, as it's mostly done in this country with hyaluronic acid fillers, is not a problem having a rhinoplasty afterwards as long as the filler is dissolved well.
Perfect. I'm at the end of my question list. Does anyone else have any questions that they'd like to ask?
Cool. Well, I appreciate everyone's attention. Here, let me there we go. I appreciate everyone's attention today. I hope that it's been somewhat helpful, and we look forward to seeing you in person and hearing from you.